Good morning and Happy New Year, everyone. I'm glad to see everyone with us today. Thank you for joining us for January's edition of Health Bytes with Region 3. So it's my pleasure today to welcome this month's speakers. With us today, we have Lindsay Gypin. She's the data project manager / curator for the National Neighborhood Data Archive for the Institute of Social Research. She earned her Master's of Library and Information Science with a certificate in Research Data Management at the University of Denver. We also have Marilyn Sinkewicz, who's a research investigator in the University of Michigan's Institute for Social Research. She is a psychiatric epidemiologist who studies the social, economic, and historical causes and consequences of mental health disparities. And then Philippa Clarke is a research professor at the University of Michigan's Institute for Social Research and professor in the Department of Epidemiology. She is a social gerontologist and a social epidemiologist with over 2 decades of research on neighborhoods and health. So in today's Health Bytes, our speakers will give a presentation on the NaNDA Open Data Resource for Health Science Researchers. So thank you everyone for being with us today, and I'm going to hand it over to our speakers to take it off.
Hi, everybody. Can everybody see the slides okay? I probably want to hit the presentation button. Okay, so we should see the title slide. Thanks so much, Katie, for the introduction. We're really excited to be here and to talk with you all about the National Neighborhood Data Archive, which is an open data repository that we think a lot of your researchers will get a lot of great use out of. So we're super excited to talk about it. Before we start, we wanted to take a moment to acknowledge our funders. NaNDA is funded by the National Institutes of Health through the National Institute of Nursing Research, the National Institute of Minority Health and Health Disparities, as well as the National Institute on Disability, Independent Living, and Rehabilitation Research. This is just an overview of our presentation. We'll be discussing a little bit about what NaNDA is and how it can be useful to you all as librarians, specifically health sciences librarians. Dr. Clarke will talk about neighborhoods as a social determinant of health. We'll show you where to find NaNDA and how easy it is to download. And then Dr. Sinkewicz has put together some really incredible data visualization slides that will give an example of what you can do or what your researchers can do with this super awesome resource. So first, a little about NaNDA. As we mentioned, it's an open data repository, and it does adhere stringently to the FAIR principles of findable, accessible, interoperable, and reproducible. It's highly curated and free and very easy to download through ICPSR. The other thing that's really nice about it is that there's a bunch of different data sets that your users can download, and they can link those together, and then they can easily link them with their own data. So if you're working with researchers who have health records data, or maybe they're doing survey research, any kind of participant data that has a geographic identifier, they can easily link to all of the different resources available in NaNDA. Every data set in NaNDA represents one topic. We'll show you a list of some of the topics in a minute. And they go over elements of the physical, social, demographic, economic environment. That's what Philippa is going to talk about a little bit in a minute. Some of them go over one point of time, so say 2020, if you have researchers that are looking at the pandemic specifically, and some of them are longitudinal and go over various points in time from 1990 to 2020. And then we're talking about GIS, but our data is tabular. It's in columns and rows and can be downloaded in a variety of formats. It's SAS, we've got CSV files, but if your researchers are not GIS experts, that's okay. It's just tabular data, and they'll easily be able to link it as long as they're familiar with using tabular data. I'm not a GIS researcher, so I don't know if any of you all are experts, but this is just a little overview of what we're talking about when we talk about geography. So our data covers the nation, and it's broken up in a variety of different ways. And this is just one sort of example of how you can break up geographic location in the United States. This is from the Missouri Census Data Center. So you're probably familiar with regions and states. We're here with Region 3, and y'all are from a variety of different states. You were listing them in the chat as we came in. We're trying to get at the neighborhood level, and what does that mean? But also, because we have open data that's aggregated from other sources, what can we safely publish? Obviously, we can't publish information that's private under people's HIPAA records and things like that. So what can we publish about the location, and what geographic level can we publish that safely without giving too much information away? So the data that we have right now is broken up. We have most of our data sets are by the census tract and the zip code tabulation area. So if you have participant records that have zip codes or happen to have a FIPS code for a census tract, that's going to really easily link to NaNDA. We have others that are by, say, county or school district. It really just depends on what our data source was. So for example, obviously school district data is at the school district level. Our voting records data is at the county level, and then Marilyn's going to talk about data that's at the police jurisdiction level later. But you'll notice this is kind of like how it sort of all flows together and goes up. If, say, you have NaNDA data that's at the census tract, but maybe you only know the state that your survey data comes from, you can very easily aggregate that up to the state level. So here's just a list of some of the topics that we thought might be relevant, particularly for you all here. Our socioeconomic affluence and disadvantage measure is one of our oldest and most popular measures that folks download a lot. Healthcare services, of course, weather is a new one, etc. As an example of how easy it is for researchers to use NaNDA, we have this study called Cognability, and this slide is actually different from the ones I sent over yesterday. So you might just take a screenshot or jot down that URL while we're on this slide. But cognability is a theory that describes how well your neighborhood can support cognitive health. It has a really cool interactive feature where you can go on the website and enter your address, and it will tell you about the cognability of your neighborhood. And what it's doing is it's looking at a bunch of different NaNDA data sets, and it will tell you on the website which ones to sort of tell you which amenities are in the neighborhood that your zip code is in, and how that feeds into that theory of cognability. Another way that you all could use NaNDA data is as an example of fair data concepts. A lot of data is available on the internet. I'm sure you all are familiar with the concept of the data deluge. NaNDA is fair, it's very clean, it's easy to download, and we have researchers here who are promoting open data because that socioeconomic status measure is one that folks were recreating, and Philippa, years ago decided, why don't we just make this publicly available so everyone can use the same thing? Now we're being standard, and we're starting with our research questions instead of with creating this measure of socioeconomic status. So it's open and available. It's a great example of fair data. Also, we are always working on new data sets. So these are some of the topics that we're working on right now. We actually just wrapped up a data set on essential workers that should publish in the next month or two. We're hoping to re-envision our voter turnout and partisanship data set. We're working on measures about the pandemic. Again, that's what Marilyn will talk about shortly. As well as other things. If you have an idea and you look at NaNDA and you think, oh, there's a gap here, it'd be really cool if they had data on X, we'd love to know. Reach out and let us know. So with that, I'm going to turn it over to Philippa, who's going to talk about neighborhoods as a social determinant of health.
Thanks, Lindsay. Yeah, I mean, I think this is so important to think about, and I'm just going to give you a quick overview about the research that goes on neighborhoods and why it's important and considered a social determinant of health. And what do we mean by neighborhoods? We mean where we live, but where we were born, where we have been going to school, where we go and recreate and play, where we go to work. It's all the places that we experience in our day-to-day lives and over our lives, the life course. So there's been increasing attention, as you all know, to the social determinants of health. So Healthy People 2030 is really identifying those social factors that impact health over the life course, including access to education, economic stability, healthcare access, but it also specifically identifies neighborhood features. So the neighborhood built environment, as well as the neighborhood social environment. So this is really, really exciting for me to finally see that neighborhoods are being recognized as on a federal level as a social determinant of health. Next slide, Lindsay. So how are the different ways in which the neighborhoods can affect health or be important for health? And we think about the built and physical environment. These are features in the environment that are human-made or that are relevant, that are representing of the physical environment. Things like walkability. How walkable is someone's neighborhood? That can have a big impact on their ability to maintain physical activity, to access destinations without having to use a car. Similarly, access to public transit can mitigate, car use, especially for people as they age and are unable to drive. Traffic is a hazard for people who are aging as well. Many lanes of traffic can be hard for people to navigate. Proximity to different destinations, so access to food stores and recreation are important for cardiovascular health, as well as arts and culture and healthcare as being important not only for access to resources to maintain health, but in terms of just stimulating one's cognition and mind and being able to maintain intellectual pursuits even after retirement. The physical environment captures things like the social and the toxic environment, air pollution, and climate and weather. These are all things that are being shown as well with climate change to be important for the health of vulnerable populations who may not, for example, have access to air conditioning and more vulnerable to extreme heat or events. Next slide. So while the physical and built environment are things that we can actually see, the social environment is something that's actually less visible but has a tremendous impact on health. So Lindsay mentioned the socioeconomic disadvantage and affluence measures. These are measures that are capturing concentrated economic disadvantage in a community, as well as concentrated affluence that can have spillover effects on community cohesion, as well as have impact the resources that are distributed in those neighborhoods. Other social processes like racial segregation or gentrification are also shaping health outcomes in the community, as well as other things, as Lindsay mentioned, voter registration and turnout in terms of indications of community response and community cohesion. Next slide. So how does NaNDA capture these neighborhood characteristics? Well, we typically use what we call secondary data. So these are existing data sets or existing data that are publicly available or available sometimes proprietary. We take these existing data sets that are often just simply business locations, for example, or census data, and we aggregate them and you create them theoretically to provide users with measures of neighborhoods that can inform research questions. So as we say, we use data from the American Community Survey or census data to create our measures of neighborhood socioeconomic status. But we also capture data on housing characteristics that we have been able to create using Zillow data, ZTrax data. These data have restrictions on whether and how we can publish them, but we have a data use agreement that allows us to publish these as aggregate characteristics. Similarly, the business establishment data, while that is proprietary, we have permission to create aggregate metrics of the density of resources of different types of businesses in neighborhoods and make that available publicly through NaNDA. I put another few examples here of the kinds of secondary data sources that we use, but it can give you a general sense about how we are using existing data to create measures that for the public to use in their research. Next slide. All right, I'm going to pass this back over to Lindsay.
All right, so we're going to show you briefly, if I can get to it. Can y'all still see my screen? Philippa or Marilyn, will you nod? Okay, great, thank you. My little green arrow disappeared. So I'm going to show you how to get to the NaNDA data. I think the easiest way is to go through the website. So Katie, if one of y'all will drop that URL in the chat, that would be great. It's just nanda.isr.umich.edu. This is our website. There's a lot of great information on here. We're just going to be looking at how to access the data right now. So I'm going to go right to the data tab. And unfortunately, we're in the process of redoing this data tab. It's going to be a lot better, a lot more robust, and a lot more user-friendly, hopefully very soon. But right now, there's a table that lists some of our topics. Ignore that. It's going to be so much better in a couple weeks. And we're just going to click on this link over here where it says NaNDA repository on ICPSR. And it gives you just sort of an overview. You can get here just through ICPSR if you're familiar. Gives you an overview of the data, and then down below is a list of all of our data sources. Also important to note, if your institution is not a member of ICPSR, you can still download NaNDA data. There are some data sets on ICPSR that you won't be able to access, but we use our funding from NIH to make sure that our data is open and available to anyone to use, because we really believe in open data. So you'll see there's 16 different data sets. Those are kind of the topics. Each one of those has more than one download. I'm going to go to our socioeconomic status and demographics data sets under 11. And this page gives you kind of some information about the data set that you can look at. You can look at a list of variables under the data and documentation tab. You can preview the codebook. You'll note that there's two. ICPSR generates sort of a list of summary statistics that they publish and call the codebook. But this documentation tab gives you the detailed information about the provenance of the NaNDA data, where it came from. It's got, I like to think of it as a miniature literature review around why we created the data set, what existing research there is. And then we also often have a usage note about suggestions on how to use the data. Some of these even say, you know, the street connectivity data set and the primary roads data set link really nicely together. You might want to look at, you know, these two together. But what I wanted to really highlight is this downloads tab. Like I said, you can download it in a variety of different formats. And it's as easy as clicking on it. There's a terms of use that says, I promise to use the data for good, pretty much, and then agree, and it's already downloading. Folks, we get emails sometimes with folks asking, you know, how do we get this resource? It's easy. Just go to the repository and download it. So right now we have 30 data sets. They've been downloaded over 27,000 times. And oh, I forgot to show, there's also a data related publications tab where I clicked the data and documentation tab. Two more over is a data related publication. So if you wanted to see what articles are being written about this data, you can see it from there too. But there's 68 publications on this data. So again, an example of fair data. Our data is open. And because it's open, it is leading to increased citations for our researchers. This is a list of all of the places you can go to get our data. We are in the process of migrating from open ICPSR to ICPSR. That just means it's got another level of curation, and it's more easily discoverable by your researchers. Some of our data has not migrated over yet, but if you go to the NaNDA website, it will take you to either of these. If you have any questions, please don't hesitate to email our help desk. It's that nanda-admin@umich.edu email. And then I'm going to pass it over to Marilyn.
Thanks, Lindsay. Can you hear me? Good morning, everybody. Great. So our aim in this part of the presentation, the next part of the presentation, is to give you a sense of the kinds of questions that can be answered and the information that can be provided with NaNDA data. And we'll show you a few examples of how this information can be visually communicated to various types of audiences. Next slide, please. To do this, we're drawing from a project with my colleagues Philippa, Clarke, and Iris Gomez at the University of Michigan. In this project, we're examining the dynamics of mental health care provision in the US over the past 2 decades. This is part of a larger project that eventually will look at links between mental health of communities and the economic health of communities. But today we'll show you some preliminary results, trends, and patterns about mental health care. Not ready yet for prime time, but we'll give you a sneak peek. First, I'll say a brief word about the data we're using and the way in which we're measuring the provision of mental health care. Next slide, please. Our study uses data supplied by Data Axle, which is an organization that compiles information on businesses and healthcare across the United States. The data come from a wide range of public sources, including telephone directories, government data, police data, Chamber of Commerce, etc. The results that we're going to show you today are based on a subset of this data related to mental health care over the period 1997 to 2020. Next slide, please. So how do we measure the provision of mental health care in communities or in states or cities, etc.? In this study, we aggregate several variables into 2 main categories. The first category is mental health providers. It includes primary care physicians because we know that they're on the front lines for patients with mental health problems. We also include mental health physicians, that is psychiatrists, and other kinds of practitioners such as psychologists, social workers, etc. The second category is mental health facilities. This category includes both inpatient and outpatient psychiatric and substance use hospitals, other kinds of facilities as well as help for suicidality and addiction problems. Next slide, please. Although we are conducting a national study, meaning we have data for the entire United States, we thought that local and regional analyses may be of particular interest to you today. So that's what we're using to give you a sense of what it's possible to accomplish with NaNDA data. As I said, we're presenting some preliminary analyses that we've done for the city of New Orleans and for the 7 states in NNLM Region 3. There are 2 main takeaways from the charts and maps that you'll see presently. First, 1, you'll see how mental health care provision has changed over the past 2 decades. And 2, you'll see how mental health care provision is unevenly distributed across various geographic areas. And also just a note that mental health, all the mental health care numbers that you're going to see in the maps and charts are adjusted to the size of the population. For example, per 10,000 people in New Orleans or per 100,000 people in the state of Arkansas. So next slide, please. Okay, we're just going, yes, exactly. So we are now looking at a heat map, what we call a heat map of the city of New Orleans. It shows the number of mental health providers per 10,000 people and the number of mental health facilities per 10,000 people across the 8 police districts in the city. The black lines on the map, it's a little hard to see them, show the boundaries of the police districts. We use police districts because they roughly map onto the main neighborhoods in New Orleans, and that allows us to see differences in the availability of mental health care across various communities in the city. The color of the police districts represents the number of mental health providers, again per 10,000 people, that are available in the district. As the legend on the right, if you take a look at the legend on the right, indicates, police districts that are yellow and green have proportionately more providers than those that are orange and red. The size of the bubble in each police district represents the number of mental health facilities for 10,000 people in that district. So if we look at Police District 7 up there, right, New Orleans East, it had in 1997, because we're looking at 1997 data right now, New Orleans East had 27 providers for 10,000 people, no facilities, and a population of about 86,000 people. By contrast, if you look at Police District 8, where the French Quarter is located, and the business district, it has a population of about 1/9 the size of New Orleans East, but it has almost 1,000 providers for 10,000 people, nearly 40 times that of New Orleans East. It also had one mental health facility for 10,000 people. Now, if you turn your eyes to the bottom, you'll see a slider at the bottom of the map that shows the 23 years of the study from 1997 to 2020. We're currently looking at 1997 data, but let's start the slider and observe how mental health care provision changes over the next 2 decades. What we're seeing is that both the number of mental health providers and facilities improve proportionately in every police district. By 2020, in fact, we'll see that in Police District 7, 2020, New Orleans East, we've gone up to 24 providers for 10,000 people, and we have one facility for 10,000 people. However, if we go back to Police District 8, it now has over 1,000 providers for 10,000 people and jumped up to 14 facilities. So this analysis suggests that improvements in mental health care provision have been laudable, but they have not been distributed evenly across the city. Generally, I think we can say that it's a generalization, but some of the more expensive residential districts in the southwest corner of the city, which include the French Quarter, the Garden District, Mid-City, etc., they have experienced greater improvements than areas like New Orleans East, where large groups of immigrants and people of color reside. So this just suggests that disparities in mental health care provision have widened, in fact, over the past 2 decades in New Orleans. The next map shows the same information, this time for the 7 states in Region 3. Similarly, the color of the state indicates the number of mental health providers per 100,000 people this time, and the size of the bubble in the state indicates the number of mental health facilities per 100,000 people. So in Nebraska, up in the north, with under 1 million population, Nebraska had in 1997, Nebraska had 183 providers and 11 facilities for 100,000 people. In the same year, Louisiana, in the south, with approximately the same population as Nebraska, had about half the number of providers and facilities proportionately. Let's see what happens over the next 2 decades. Notice that eventually, you'll notice that as the slider moves, every state gets greener year by year. There's a little noise in it, and the bubble in every state becomes larger. So this is the good news. But again, we'll see at the end of the day in 2020 that improvements are uneven. By 2020, Texas, with about 5 times the population of Nebraska, has 1/3 fewer providers per 100,000 people and 40% fewer facilities per 100,000 people than Nebraska, a disparity that actually grew much larger over the 2 decades. Next, we'll show you exactly this same information, but in a different format, in a bubble chart. Here, the circles represent the 7 states in Region 3. Texas is gold, Nebraska is purple, and so on. The size of the circle corresponds to the size of the state population. In 1997, there were about 17 million people in Texas. The x-axis shows the number of mental health providers per 100,000 people, and the y-axis shows the number of mental health facilities per 100,000 people. In 1997, Nebraska, in purple, has the most providers per 100,000 people, and Kansas, in green, has the most facilities. And initially, in 1997, all the states are loosely clustered on the left-hand side of the chart. But let's see what happens over the next 2 decades. Again, what we're observing is that mental health care improves for all states over the 23 years. Everybody gets better. They all move gradually into the upper left-hand quadrant of the chart, meaning relatively more providers and facilities per 100,000 people. However, by 2020, the states appear to be divided into 2 groups, loosely. Texas, the large gold circle, and Arkansas, the small yellow circle, lag notably behind the rest of the states. And did you notice the sizable improvement in 2020 for all the states? There's a story behind this big bump up. A recent study by the RAND Corporation shows substantial increases in mental health care utilization and spending that are related to COVID, the pandemic. Our group now has access to data through 2022, so we will be investigating this and reporting back further. The last chart we'll look at today shows this same information for Region 3 states, except now we disaggregate the rural and urban areas of the states. This distinction, this rural-urban distinction, is important because we know that services for people with mental health and substance use problems can play out very differently in rural areas compared to urban areas. For example, in rural areas, the population is much more geographically sparse. Further, supports like psychiatric services and emergency shelters, which are fairly common in urban areas, may not even exist at all in rural areas. So the chart has the same color scheme for the states, but now the triangles, the diamonds represent rural areas of the states, and the circles represent urban areas. So looking along the x-axis, we notice that in 1997, where we start again, urban areas have proportionally more providers than rural areas. And also notice that except for urban Nebraska, all the rural and urban areas cluster in the bottom left quadrant of the chart. But let's see what happens as we start our time travel here. We are noticing that in rural areas, the diamonds migrate up the y-axis to the top left quadrant, indicating increases in facilities over time. At the same time, in urban areas, the circles migrate across the x-axis to the bottom right quadrant, indicating increases in providers. The result is that this rural-urban difference that we saw in 1997 in facilities and providers actually increases over time. Also, we see that the group of rural diamonds becomes further apart on the chart than it was in 1997, as does the group of urban circles, suggesting increasing disparities over time. Additionally, the gold and yellow circles on the map suggest that it is the urban areas of Texas, gold, and Arkansas, yellow, that may be driving the relative disadvantage that we observed in the previous chart. Finally, we'll just make one final comment on this. Over time, in both rural and urban areas, the large Texas population remains at or near the bottom of the distribution of mental health care across Region 3 states. Not so with Louisiana. In 1997, Orange, Louisiana was the only state with lower provision of mental health care than Texas. But by 2020, what we're looking at now, Louisiana improved its standing among the states. So doubtless there are many stories, interesting, fascinating stories behind these trends and patterns, possibly related to changes in demographics, policy, politics, the environment, human and natural disasters like we have down here in New Orleans, and so on. But for today, we'll leave it here and I'll turn it back to Lindsay.
All right, thanks so much, Marilyn. Those were really, really fascinating charts and graphs that you shared with lots of relevant and interesting information. That is really all we had for you all today. We definitely have time for questions. I wanted to put up our contact information again. As I mentioned, any questions you can send to our help desk that's monitored by Philippa and I, and we have a 24-hour turnaround response. We don't always answer your question within 24 hours, but we'll get back to you and say we're working on it. We are on X, though we're moving away and looking at what the future may be for our social media presence. We do have a LinkedIn account and an Instagram account. Those are all at @UM_NaNDA. And then, of course, our website where you can go and access our data as well as other information. So I'll go ahead and hand it back to Katie.
Thank you all. This was a fascinating presentation, so thank you for this. And so I'd like to open it up for questions for anyone. Please feel free to drop it in the chat. We did have a couple of people, a couple questions already. Someone was asking if someone wants to use the data for commercial purposes, like a report that they're going to sell or even putting on a t-shirt. Is commercial purposes allowed for this data?
I think it's under a CC0 license. It would tell you when you read the fine print on the use the data for good data use agreement. Yeah.
And then someone also wanted to know how often is the data updated or where can they find that information?
So we, as often as we are able to, but with a small team and as many data sets as we have, not as often as we like. The best way to get information about data updates is from the news tab on our website, or either our LinkedIn or our Twitter pages. Anytime we have a data update, we publish a little data sort of blast on our news page and then try and repost that to our social media accounts. So right now we're really working on updating all of the data sets that are based on our National Establishment Time Series data, which is our business data. So things like the healthcare services, grocery stores, those are what we're working to get republished right now. And then we're also working on our new measures of hopefully the voting one. We're working on one on LGBTQ plus health, and police presence is another really exciting data set that we're working on right now.
And then someone also asked, how do we get to the mental health care providers and facilities site that you just showed?
Yeah, so like Marilyn said, that is a preliminary study and that data is not yet published. It just so happened that she was focusing on New Orleans, and since Region 3 includes New Orleans, we thought it would be a great example to show what we're working on. So that data has not yet been published. It is in the pipeline, but yeah, we don't have an ETA on getting that published yet. She did, I think, put the title of the article in the slides. That was the slide on the slides, right, Marilyn? So you could keep an eye out for when that paper gets published. That paper hasn't been published yet either, right? No, yeah. So keep an eye out for when that gets published. We'll probably do a social media blast about that paper getting published as well.
I would just also add that on Open ICPSR, we do have mental health provider data in the healthcare services data set, but it doesn't go through till it's only up till 1997.
Thanks, Philippa.
And then other than social media, are there email updates that you can sign up for?
Yeah, on the news tab, I can show that too. On the news tab, there's a subscribe to news in the upper right. So real quick, I'm going to post in the chat a link to the open ICPSR that will take you directly to the healthcare services data sets. There's two, one for zip code tabulation area and one for census tract. They have the same info, it's just by different geographic identifiers. And then the website, is it okay if I share again?
Yeah.
Great, thanks. So on our website, this news tab here, and we got some feedback yesterday, so we may rename this page, but it's news right now. You can subscribe here and it will send you an update anytime we post something to that news page. Right now, we've mostly been doing data publications, trying to make sure that anything that goes to people's inboxes is highly relevant.
I was curious, Marilyn, what tool did you use to create those data visualizations?
That's a great question. And I'm not sure if Iris is on the call or not, or if she would like to speak to that. But yeah, we have a really great data scientist who is really does superb data visualizations for us too. So I'm not actually making those. But I think Iris, Philippa, do you know what she's working in to create these visualizations? I don't know if it's R
I think it's Python.
Python. But there's also packages in R that will create these visualizations. I've worked before with R, and they have really good packages for creating data visualizations.
Okay, awesome.
And we hope eventually to have some of these up on our website, and perhaps even in the future, templates that you can use to produce the same kinds of visualizations and more.
There's Iris in the chat. She says it's Python.
It is Python. Okay.
Yeah, that was what I thought too. Thanks, Iris. Also, Iris, mega props. Those charts are really fantastic. Thank you so much for building them.
And then someone also asked, do you offer presentations to other university departments who'd be very interested in this resource?
We are building up our training program. So I would encourage anybody that's interested, we would love to. So please shoot us an email. It's nanda-admin@umich.edu, or you can send it to any of our direct emails too. And we would love to coordinate something. And we are working on building up our training program to have more training opportunities available to wider population as well.
And I'll drop that email in the chat. It's the NaNDA, you said NaNDA-admin. Is that the correct one?
Yes. Yeah.
Okay. I'll drop that in the chat for people to, if they want to reach out. And then someone, this isn't so much a question, but just somebody mentioned that they would love to see health literacy statistics and general literacy statistics added to the data sets.
I saw that too, and I flagged it. Thank you.
I think that's it for the questions. I'm going to scroll back through, give people a second to type out any last minute questions. I think I got all of them.
So if there's a bit of a pause here, I just wanted to respond to some of the comments in the chat that I think are such important comments about the context in which these data are presented. As social scientists and I'm a health disparities researcher, we are very aware of this, and I would like to say sensitive. We're not always as sensitive we should be, I'm sure, but all that to say, I very much agree with these comments about it's important to provide context. It's important not to talk about causality when we haven't done causal analyses. At the same time, it is important also just to present the evidence, but to give some context for the evidence. I did mention, and I was trying to allude to this, that there's so many stories behind these numbers that need to be told. And so I would say for myself, before I actually publish these, I would round out, have much more information on the context and be able to provide that to people so that the various audiences don't jump to conclusions that are not necessarily there. So I just wanted to flag that. Thanks a lot for those comments. I don't know, Philippa, if you had anything to add to that.
No, I was going to actually just comment on the same thing. I thought there were some really great comments, I think, from Jennifer Lloyd about really sort of insights in the New Orleans context.
And we did get one more question in. Do you have household pets data?
I saw that, and no, but I am definitely, since it was in this presentation, I'm definitely going to put it on our next meeting agenda as a possible new NaNDA data set. I do think if that's data that you need, I think you might be able to find a data set on Kaggle that has, I vaguely recall using some at least household cats data from Kaggle when I was in grad school.
I think that's the end of our questions. Thank you again so much. This was a wonderful presentation. I really enjoyed it. I love those visualizations. That was very cool. So thank you all so much, Marilyn, Philippa, Lindsay, thank you.
Thanks so much for having us. We had a great time. And please, if anybody has questions, reach out. We'd love to hear from you.